Dr. Roger Henderson, and I'm one of the GP Notebook study group hosts. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. In this episode, we'll be discussing hypertension in pregnancy, or gestational hypertension. Now, we sometimes forget that hypertension is the most frequently identified medical problem during pregnancy. And in England, gestational hypertension and preeclampsia complicate around 5% of pregnancies, significant numbers. And in America, this is now as high as 13%. The incidence of hypertensive disorders of pregnancy is higher in healthy nulliparous women, with the highest prevalence being in women aged over 45, with black women being at greater risk than white women. Women with pre-existing medical conditions, including chronic hypertension, diabetes, renal disease, and autoimmune disorders, are particularly at high risk, and a personal or family history of preeclampsia is also an important predictor here. Now, over recent decades, the incidence has risen in many regions, likely reflecting shifts in maternal demographics, such as increasing maternal age and higher rates of obesity and chronic disease. But at the same time, the incidence of severe complications, such as eclampsia, has declined in settings with strong healthcare systems, largely due to better prenatal surveillance, earlier detection and timely intervention, including the use of antihypertensive therapy and seizure prophylaxis. So a definition. Gestational hypertension is defined by blood pressure readings of 140/90 or higher on 2 occasions at least 4 hours apart after 20 weeks gestation in a previously normotensive woman, without the presence of proteinuria or other clinical features suggestive of preeclampsia, such as thrombocytopenia, impaired renal or kidney function, pulmonary edema, or new onset headache. However, and this is a really key point I want to stress here, women with gestational hypertension are typically asymptomatic. Now, the exact etiology of gestational hypertension remains unknown, but it's thought that insulin resistance may mediate the clinical onset of hypertension in pregnancy. And it's also increasingly viewed that hypertensive disorders of pregnancy are not a single condition, but rather a continuum. So at one end is chronic hypertension, which either predates pregnancy or is identified early in gestation, and at the other end are severe complications such as eclampsia. And in between lie gestational hypertension and preeclampsia, which may progress in severity over time. Now, understanding this continuum is important because it highlights the dynamic nature of these disorders. So a patient may initially present with mild hypertension and later develop significant systemic involvement. And this progression underscores the need for ongoing monitoring rather than one-time assessment. Now, even in the absence of these factors, first pregnancies carry a higher baseline risk. And so this reminds us that all pregnant patients require careful blood pressure monitoring, regardless of perceived risk level. The pathophysiology of gestational hypertension is also not completely understood. Blood pressure is usually elevated in pregnancy because of upregulation of the renin-angiotensin-aldosterone system, but this is balanced by a drop in the systemic vascular resistance and cardiac output. Now, in women with gestational hypertension, this resistance remains low, but cardiac output tends to increase. So as I say, a reading of 140/90 millimeters of mercury or higher is considered abnormal in pregnancy, and hypertension in pregnancy is considered severe if the systolic blood pressure reaches 160 or the diastolic level reaches 110 millimeters of mercury, or both. Now, if faced with severe hypertension, the diagnosis may need to be confirmed within minutes to facilitate timely antihypertensive therapy. And these women should be diagnosed with preeclampsia with severe features and require urgent management. And we as GPs should be alert to other indicators, including a low platelet count, impaired liver function, renal insufficiency, pulmonary edema, or neurological symptoms such as a persistent headache or visual disturbances. As the condition worsens, patients may develop severe features such as very high blood pressure, significant neurological symptoms, severe abdominal pain, or respiratory compromise. And at the most severe end of the spectrum is eclampsia, defined by the occurrence of seizures in a patient with preeclampsia. Now, although this is less common now than in the past, it still remains a life-threatening emergency requiring immediate treatment. Closely related here is HELLP syndrome, a severe variant characterized by haemolysis, elevated liver enzymes, and low platelet count, hence HELLP, HELP. These patients often present with non-specific symptoms such as malaise, nausea, and right upper abdominal pain, which can make an early diagnosis challenging, and so a high index of suspicion is therefore essential. Now, when we evaluate these patients, accurate and repeated blood pressure measurement is obviously fundamental. If the woman's previous blood pressure status is unknown, your initial reading should be regarded as the baseline. And so distinguishing gestational hypertension from chronic hypertension may only be possible after the pregnancy. And in addition, laboratory investigations are critical for assessing disease severity and organ involvement. Now, these typically include renal function tests, liver enzymes, platelet count, and assessment of proteinuria. On a diagnosis of gestational hypertension, ultrasound examination of estimated fetal weight and amniotic fluid index, and umbilical artery Doppler velocimetry are recommended. If you suspect preeclampsia, then a range of additional maternal and fetal investigations may be recommended, including fetal cardiotocography and, if available, the use of placental growth factor-based testing may reduce the time to a diagnosis of preeclampsia, with a consequent reduction in the incidence of severe maternal adverse outcomes in women presenting between 20 to 36 weeks plus 6 days of gestation. If we look at management strategies now, these depend on both disease severity and gestational age, and preventive measures play a key role here, particularly in high-risk populations. Low-dose aspirin, initiated in early pregnancy, has been shown to reduce the incidence of preeclampsia in selected patients, and when hypertension develops, treatment is guided by the blood pressure levels. So if lifestyle interventions fail to control the blood pressure and it remains above 140/90, antihypertensive medication is recommended with a target blood pressure of 135/85 or less. Labetalol is usually considered the antihypertensive of choice here and is effective as monotherapy in 80% of women. It seems safe and effective for the management of hypertensive disorders of pregnancy, but should be avoided in women with asthma or any other contraindications to its use. Oral nifedipine may be as effective as intravenous labetalol and can be considered in cases of deteriorating hypertension previously controlled with oral labetalol. Oral monotherapy with labetalol or nifedipine is effective in most cases, although some women do require combination therapy. Severe hypertension requires prompt pharmacological intervention to reduce the risk of complications such as stroke, and all women with persistent severe hypertension should be admitted to hospital and started on antihypertensive medication, typically labetalol, either oral or intravenous, oral nifedipine, or intravenous hydralazine. But despite all these supportive measures, the definitive treatment remains delivery. A planned early delivery before 37 weeks of gestation should not be offered to women with gestational hypertension whose blood pressure is lower than 160/110 unless there are other indications. And these indications include preterm labour or premature membrane rupture, vaginal bleeding, abnormal fetal testing, intrauterine growth restriction, development of preeclampsia or eclampsia, and evidence of end organ damage. Women diagnosed with gestational hypertension at or beyond 37 weeks gestation are generally best managed by delivering the baby by induction within 24 to 48 hours after maternal stabilization rather than expectant management. Routine induction of labour in women with hypertensive disorders at 34 to 37 weeks significantly increases the risk of neonatal respiratory distress syndrome, although there is evidence to suggest that planned early delivery after 34 weeks is associated with a reduction in maternal morbidity and mortality. If we look at potential complications now, for the mother, these can include seizures, stroke, pulmonary edema, renal failure, and coagulation abnormalities. HELLP syndrome represents a particularly severe manifestation here, with significant risks of morbidity. For the fetus, complications often arise from impaired placental function, and so include growth restriction, reduced amniotic fluid, placental abruption, and compromised oxygen delivery. But the most important factors influencing maternal and neonatal outcomes are the severity of hypertension and the presence of any end organ damage rather than excess protein excretion. Now, whilst delivery often leads to a rapid improvement, the risk of complications doesn't end immediately. The postpartum period, especially the first few days after delivery, still remains a vulnerable time, and so continued monitoring of blood pressure and clinical symptoms remains essential. And patients should be educated about warning signs that require urgent medical attention here, such as a severe headache, visual disturbances, or shortness of breath. In the longer term, women who experience hypertensive disorders during pregnancy are at an increased risk of developing chronic hypertension and cardiovascular disease. And so this highlights the importance of ongoing follow-up and preventive care beyond the immediate postpartum period. So that's a quick overview of gestational hypertension, and I do hope you found this podcast helpful for the next time you see a patient with this condition. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or even ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.